So now let's talk about the fundamental transducers, or the common transducers that are used in the point-of-care ultrasound setting. First, we have to talk about essentially what the design of a transducer is. So there's three basic criteria that are talked about when you're looking at a particular transducer. One is the size, another is the design, and finally the footprint. In addition to these are sort of the physical aspects of the ultrasound probe. You'll then look at the frequency that should be identified in older ultrasound probes to help determine which probe is appropriate for based on which point-of-care ultrasound exam you'll be doing. This is an example of the common ultrasound probes that we regularly see throughout the hospital. We have our transesophageal echocardiogram probe designed to have a very small footprint right here. We'll talk about that more in a second. And again, to go through the esophagus, you'll have a cardiac or phased array probe, you have a linear probe, and you have a curved linear abdominal probe. So these are the three probes that we'll really try to focus on, again, with the point-of-care ultrasound umbrella. The choice of transducer, again, is very important to realize that the first thing you want to look at is not just the size and shape, but also the frequency that you'll need to insonate the organ of interest. So identifying the frequency, which should be labeled on all ultrasound probes, is key to determine if it's the appropriate probe to use for sonography of the particular organ that you're interested in. The other is, again, the footprint, which is essentially the space in which the ultrasound probe is coming out of. So different footprints lend themselves to be placed in different parts of the body to, again, be appropriately positioned in those acoustic windows. For example, the phased array or the cardiac probe, there's a reason why it's nicknamed the cardiac probe, because it has a very small footprint. And that small footprint allows it to shine in between rib spaces to get the majority of the ultrasound wavelength coming from the small footprint to allow it to penetrate into deeper structures. Again, so the small footprint here is one of the classic things that we look for in identifying the phased array or cardiac probe. Similarly, this curved linear probe is frequently the abdominal probe. You can see it has a much larger footprint, and therefore placing it over rib spaces would just innately cause a lot of loss in ultrasound wavelength simply because the footprint is so large. The other, again, we talked about the fact that frequency is key to identify the particular probe. I have listed here the particular frequency ranges commonly used for these type of probes. The lowest frequency is the cardiac probe. You can imagine that cardiac structures are deeper in the body, and so we need a lower frequency probe, generally 3.5 to 5 megahertz. The curved linear probe is considered the abdominal probe because, again, this is sort of an in-between between what organ systems you're looking at in terms of the depth from the skin, and so that lends itself to a little bit of a higher frequency, usually 4 to 7 megahertz. And then we have our linear probe, which again is used more for superficial evaluations, such as for vascular access and for regional nerve blocks, and you see the range here of 10 to 27 megahertz. Important to realize that more and more technology is allowing these frequency ranges to get dramatically higher, and therefore providing an even higher resolution for the superficial anatomy structures. So again, fundamental concept: frequency, depth of penetration, inversely related. Here's a diagram of the cardiac probe. So how does a small footprint probe, like the cardiac phased array probe, able to produce a wide ultrasound image, much wider than the actual ultrasound footprint itself? Well, it's because, as the name says, phased. The ultrasound wavelengths come out in phases, and those phases allow it to, as it scans back and forth, to stitch together a true 2D picture, allows it to produce a much wider image, despite coming from a very small footprint. So again, the phased cardiac probe allows you to get a cardiac view much wider than the footprint because it comes out in phases and then processes those together to produce the ultrasound image. The curved linear probe also makes a wider image than the footprint of the probe itself, but the nature of how this does this is simply based, as the name says, by making the footprint itself a curved nature. And by making it a curved nature, as it goes further and further away, the ultrasound wavelengths will expand and allow you to have a wider image as you go further and further away from the ultrasound probe, because again, the footprint is in a curved fashion. The linear probe, very important to realize, the linear probe, as the name says, has the ultrasound wavelengths coming out in a linear fashion, so therefore the width is exactly equal to the width of the footprint. This is fundamentally important because you'll see very different types of linear probes, and one of the biggest differences between those probes are the actual lengths of the footprint. And different lengths, for example, pediatrics, you can imagine would lend itself to a much smaller footprint because the anatomy structures that you're looking at are going to be much smaller, and you don't essentially need such a long or wide ultrasound footprint. But again, important to realize that the concept of the linear probe, the ultrasound wavelengths are coming out in a linear fashion, and therefore the footprint again is the width of the ultrasound image itself. Again, I just want to highlight again this picture here where we showed the two different types of probes placed in the exact same plot in the body, but using the lower frequency probe allows us to see deeper structures versus the higher frequency probe giving us greater detail of superficial, but then we have loss of the organ systems below simply because the probe is inappropriate to scan these deeper structures. The next thing that we need to look at is how do we get orientation on the ultrasound plane itself? So each ultrasound probe has an indicator, shown here that we've colored in, and those indicators match to the indicator on the screen. It's always important that you match the indicator of the probe to where the indicator is on the screen, because this will get you the orientation of how you need to place your probe to get the ultrasound pictures lined up or displayed as you would expect them to. So it's always, again, important to have the reference of where the indicator marker is on the screen and match that to the indicator on the probe. When we're talking about the given acoustic windows and probe placement positions, we will talk about the probe position placements using this indicator marker with the sort of standard assumption that you are in certain presets that put the indicator of the screen on the right or left side. And that's an important thing to realize. You always must appreciate where the indicator is on the screen before you can really try to get your orientation. And I encourage you, as you're going through all the modules that we have available or any point-of-care ultrasound exam, that you always appreciate when the instructor is telling you about the indicator marker and probe position placement, matching that up to the indicator, how it's shown on the screen. That will really give you the orientation. Important to realize that these indicator markers can be identified by a light, shown here, or it can be just a long line or a bump. Nonetheless, there should always be a marker on the ultrasound probe that indicate that matches, that's the indicator side, that matches to the indicator on the ultrasound screen. It's always important, as we mentioned, to always get that reference of where the indicator is, and where the indicator on the probe and where that indicator is on the screen. Important to realize that traditionally, non-cardiac presets have the indicator on the left side of the screen, while when you have a cardiac preset engaged, that will put the indicator on the right side. Now, this is not an absolute, but most cardiac presets are set in this fashion. It's always important to go through the two steps of making sure you know the relationship of the probe indicator to the image on the screen, and then backwards, the relationship of the probe indicator to the patient. So those are the two markers of being able to truly learn and appreciate different probe positions. One, to know where the probe indicator is to the image on the screen, and then relating the probe indicator to where it matches on the patient themselves. Finally, traditional movement maneuvers. So it's important to talk about the terminology that we associate when we're talking about image optimization and adjusting the ultrasound probe itself from a simple hand motion maneuver. So when we're moving in the ultrasound plane, I'll try to demonstrate with my fingers here. Imagine this is the ultrasound plane of the ultrasound probe. When you go along that plane, that motion is called tilt. When you go perpendicular to the ultrasound plane, that motion is called angle. So again, when you're moving perpendicular, that's angle, and when you're moving alongside or parallel to the ultrasound plane, that is tilt. And rotation is, as the name says, just rotating your probe such that the ultrasound plane is changing. Important to realize, every time you hold the ultrasound probe, really you should think about drawing that imaginary ultrasound plane coming from the probe to be able to see that you actually have the probe in the appropriate position to see the organ of interest. So every time you hold the probe, again, trying to imagine that ultrasound plane coming emitted, using that indicator as a marker for that. And then in terms of troubleshooting, again, tilt, moving along the ultrasound plane, angle, moving perpendicular to the ultrasound plane, and rotation, rotating your ultrasound plane. Key concept that I want to try to demonstrate that idea of always imagining the ultrasound plane is from the common vascular access or regional anesthesia. Anytime we're doing needle-based procedures, right, we're always trying to identify the needle as with the ultrasound plane. In this fashion here, I just want to show that how as the needle is progressing, we are trying to adjust our ultrasound plane so that we capture that. For example, down here, having the ultrasound plane in this fashion when the needle is not in the skin would be inappropriate because we're no longer in the ultrasound plane and therefore we would not see our needle. But as this needle is going further in, we would be in the appropriate angle to capture that needle tip, and always appreciating the ultrasound plane coming from the probe and trying to adjust the two so that you're able to match and visualize the structures or procedure needle, for example, of interest is the key thing. Okay, so now let's go into knobology. And again, we want to just review the basics of knobology for the point of care aspects. It's important to realize that any ultrasound machine that you use should group the ultrasound knobs in similar fashion. Now, where they place those groups are very, very much based on the ultrasound systems, but nonetheless, we can take these major groups to help kind of identify what associations we should see. So when we see an area that has patient identifying information, such as patient name or a study date or study entry, for example, shown up here. So here's patient. We know automatically that associated with this button should be things related to the exam or reviewing or generating reports. Those should all be lumped together in one group. The next group would be related to image optimization. So when you talk about gain, depth, and focus should all be relatively in the same group together, all trying to, again, adjust the image optimization or image quality. Those buttons should be lumped together as well. Third, the actual ultrasound modality that you're trying to use, whether it's B mode or traditional 2D ultrasound, pulse wave or continuous wave, which we'll talk about as this section goes on, or color Doppler, those modes should all be grouped in the same area as well. Number 4 is related to doing measurements and calculations on the ultrasound from the ultrasound image itself. And so when you see things such as caliper or calculations, those should also be associated to be close to each other. And finally, methods of saving the ultrasound image themselves. Whether it's videos and clips, those should all be in a relatively same feature, and they're usually close to the freeze button, which again would allow you to be able to create those 2D images. So now let's talk about knobology as it relates to image optimization. The concept of gain is just as if you were using an amplifier when it comes to sound. So ultrasound gain is essentially just an increase in the received ultrasound signals. So it's important to realize that it's just like adding an amplifier when you're talking about stereo volume. All gain does is make everything in the image brighter. It does no difference in terms of telling the difference between levels of amplitude or degrees of intensity of the ultrasound waves getting reflected back. Rather, it just applies the same degree increase of signal amplitude across the board. So in essence, it makes everything brighter. It's a post receiver alteration. Important to realize, though, that now gain has allowed us to, most ultrasound machines may have the ability to adjust levels of gain. And what that means is that you can identify certain bands alongside the ultrasound image that you can increase the gain only for those bands as well. And I'll talk about that in just a second. This is the concept of time gain compensation. So based on the time that it takes or the distance the ultrasound probe is from the the structures, or so the deeper the structures are, you can alter the gain just in those areas. So time gain compensation, you can essentially identify this as horizontal bands of gain. It's important to realize that some ultrasound machines adjust the time gain compensation automatically, because you can imagine as you go deeper and deeper, you would need to make the image quality look the same as the proximal areas. You would have to increase your gain to have that same level of gray. And it's important to realize that most ultrasound machines already do that when you try them out. Okay, so now moving into ultrasound beam depth. It's very, very important to realize that you need to make sure that you have the proper depth of the image of interest, meaning that since depth alters the frequency that the ultrasound probe is getting emitted, your image quality will get dramatically impacted based on the depth of your image. So you should always keep the lowest depth possible of the desired structure, because lowering the depth will allow you to have a higher frequency and therefore give you a better picture quality. Most ultrasound structures, images have a depth guide, usually shown in centimeters, on the right side of the screen, shown here. So the concept of ultrasound focus is essentially a method in which you tell the ultrasound machine to allow the ultrasound wavelengths to be the most linear up to that area of focus. This is important because fundamentally, as ultrasound gets emitted, they will no longer follow that linear pattern, and they may sway in one direction or not. By identifying that focus, you're telling the ultrasound machine that this is where you want the best resolution to be targeted at that particular structure. So you should always make the focus, which we'll identify in the next slide, to be at the area of best of interest. So, because that will allow you to have the best detail at that level of interest. So here I want to show again that this band right here is the focus, and by simply moving the focus down, from slightly down a few centimeters from the picture shown up here at the top, we're trying to. This is the mitral valve. This is a transesophageal echocardiogram, but we have the focus very high. We're not seeing the mitral valve with a great amount of detail. You can see this aspect of the valve is hard to see. It's very hypoechoic. Now, by just moving the focus down to the level of the valve, we can see that we're able to much more improve our picture quality of this part of the leaflet. So we're now able to see a much clearer aspect of this leaflet, really kind of assess the pathology at this level because we adjusted the focus. So it's important when you see focus to always put it at the area of interest of where you want the best 2D picture. Let's now go into ultrasound modes. So the fundamental mode of 2D is what we'll start talking about, and then we'll talk about the other diagnostic modes of ultrasound technology used in the point-of-care setting. So traditional B mode, which stands for brightness mode, or 2D mode, was what we'll first talk about, and then we'll go into the Doppler modes, which essentially allow us to look for flow patterns, and then look at the M mode modality as well to provide motion assessment over a 2D structure, and then finish off. So B mode, which stands for brightness mode, is the traditional 2D picture that we get via the ultrasound machine. It provides real-time gray level assessment of the different amplitudes of reflection and the anatomy structures. It builds these pictures through the multiple frames that are generated on every second from the screen to produce this movement ability, because the ultrasound waves are constantly getting sent and reflected back and allowing us to process the change in those reflections, which essentially produces the ultrasound image. Important to realize that frequency and depth are very important to get the appropriate 2D picture. And when it comes to frame rate, you want a frame rate at least around 15 to 20 frames per second to give a realistic illusion of motion of that area. Next, Doppler is essentially the ability of using ultrasound to visualize the change in frequency of a wave resulting from the motion of the wave on the reflector. So it uses the Doppler principle. Most of the time when we're using Doppler, we're evaluating the movement of flow, particularly of red blood flow or of blood flow. The received velocity detection is dependent on the instantaneous frequency. So what this concept is simply based on the fact that the velocity of blood moving is only assessed based on the angle of which it gets instantated. So the most important thing to realize is that you need to be as parallel as possible to that flow to be able to quantify it. So if you were perpendicular to a direction of flow, you would have no Doppler shift. You would not be able to visualize a magnitude or the direction of flow because you're perpendicular to that flow pattern. You need to be parallel to be able to assess the flow direction and then be able to quantify its magnitude. And the rule of thumb is that you always want to be at least no less than 60 degrees within the angle of that flow. So let's talk about, again, the Doppler frequency principle is based on the fact that as the ultrasound probe is placed more parallel to flow, you're able to see the change in frequency if it's going forward or away, and that allows us to be able to graphically visualize this in a Doppler ultrasound waveform pattern. Very important here, again, the angle of intonation. You need to be as parallel as possible. So if I have flow in this direction, if I place my probe directly perpendicular to that flow, I would not see any Doppler waveform of significance because, again, we would not be able to assess direction or magnitude. As I get more and more parallel to that flow, I'll be able to now quantify the direction and the magnitude of that flow pattern. So when we talk about Doppler ultrasound, particularly when it comes to cardiac, we'll talk about probe placement positions that will give you the ideal Doppler waveform of allowing you to be parallel to those flow structures. There are three types of Doppler. The first is continuous wave Doppler. So continuous wave Doppler, as the name says, allows a constant sending of ultrasound wavelengths and a constant receiving ultrasound wavelengths. So what it does is that it allows you to have a summation of all the velocities in the pattern of which the ultrasound probe is emitting. So the way to think about this is that continuous wave Doppler, you will be able to identify a line of ultrasound, shown here, and that line of ultrasound, it will give you the summation of all the velocities that are detected along that pattern. Very important to realize that the continuous wave Doppler gives you a summation of all the velocities along that ultrasound plane. Let's compare that with the concept of pulse wave Doppler. So pulse wave Doppler allows you to identify a flow pattern at a specific location along that ultrasound plane. So here you see the same ultrasound plane coming from the ultrasound probe, but now what we've done based on this concept of pulse wave Doppler, you identify that you only want to sample velocities at this area. That's the difference with pulse wave Doppler. Pulse wave Doppler allows you to designate a location along this ultrasound plane in which you want to instantate the velocity. The important thing to realize with this though is that since you're now mandating to the machine that you want to assess flow at a specific location, by putting that location, based on the fundamental principle that we talked about, velocity equals distance over time. Sorry for this is incorrect here, but velocity time should be over here. But based on that principle, when you use pulse wave Doppler, you limit the range of velocities that you can assess. And that range of velocities goes further and further reduced, or that number of different velocities that you can assess gets less and less as you get further and further from the ultrasound probe. So let's review this concept. Pulse wave Doppler allows you to identify a location along the ultrasound plane shown here and only instate and get a velocity and direction of flow at that area. But as you get further and further away, since you're now limiting the ultrasound machine to say that it has to wait and assess signals reflections only at that one spot, the further and further you go away from the ultrasound probe, the less and less the range of velocities you'll be able to actually quantify and assess. Anything above that range will actually just become a reversal of flow, which we'll show in a picture in just a second. So this picture shown here is a pulse wave Doppler waveform. So you can see the two lines here, two lines. Those two lines tell us that we only want to assess the flow at this location. Compare that, and you can see you have a very nice sort of high detail flow pattern here. Let's compare that. So again, pulse wave Doppler only gives you the velocities at this one location. Let's compare that using versus continuous wave Doppler. So now we've engaged the continuous wave Doppler. Notice how those two hash lines have changed to a circle. You can look at this this Doppler waveform picture and see that it's much less sort of clear than the pulse wave Doppler. And the reason for that is because it's giving you a summation of all the velocities along this ultrasound path. So continuous wave Doppler again highlights the fact that you're getting a summation of all the velocities in this ultrasound path. So again, pulse wave Doppler identifies velocities only at this location that you can designate. Continuous wave Doppler gives you the summation of all the velocities along that path. Important to realize again the differences between pulse wave and continuous wave Doppler. So you have no limitation on the velocities that you can assess when you use continuous wave Doppler. Since you're just getting a summation of all the velocities and you're not telling the ultrasound machine that you want to designate a specific location, you have no limitation on the range of velocities that you can assess. That's the advantage of continuous wave Doppler. But compare that to pulse wave Doppler, where you get the advantage of identifying a specific location, but now being limited to the range of velocities you can assess. Let's now go into the final modality of Doppler ultrasound, which is color Doppler. So color Doppler essentially is a collection of pulse wave Dopplers that now, instead of showing you a Doppler waveform pattern, they overlay a color pattern of showing the direction and the intensity of those pulse wave Doppler signals. So again, color Doppler is essentially just using a multitude of pulse wave Doppler in the window that you designate and assigning colors to assess direction and intensity of that flow pattern. Important to realize, though, that since this window is what you identify and locate in your 2D picture, you're limited similarly to exactly how you were limited in pulse wave Doppler. So in color Doppler, you have the same limitation on that you're only able to get a certain range of velocities that you can assess. This range is called the Nyquist limit. So it's important to realize that color Doppler is essentially just multitude of pulse wave Doppler signals over a window that you can adjust, and that because of the fact that you're identifying a location and with a certain depth away from the probe, you are now going to have a range of velocities that you can assess, and that range is called the Nyquist limit. Fundamental to this concept of assigning colors to the direction and intensity of flow, one should always remember the acronym BART, blue away and red towards. So the blue color designates flow moving away from the transducer, and the red color designates flow moving towards the transducer. Again, this is traditionally how all ultrasound probes identify color Doppler. Think of the acronym BART, blue away, red towards. This cartoon again just shows the fact that so any ultrasound wave showing a signal going towards the probe would be red, and going away from the probe would be blue. Very important to realize the concept of Nyquist limit again, and this cartoon is simply saying that the range of velocities that you're able to assess is what the Nyquist limit represents. And what happens when that range goes beyond that value, or so the range of velocities does not capture all the velocities assessed in that space, meaning the velocities are higher, what you'll end up happening is something called where you're not able to longer see the direction of flow, and then you'll have simply a reversal pattern. And so let's try to make a little more sense of this. So here we see a flow pattern. If we look at our color designation here of the Nyquist limit range, remember, think BART, blue away, red towards. So the top part here is flow going back towards the probe, and the blue part here is flow going away from the probe. So when we look at the red, we can see that there's a large flow pattern going back towards the probe. And this flow pattern is getting with a higher intensity of signal. So as you can tell, simply because it starts off as a red color, shown here at the lower ranges, and then builds up to yellow, which here is designated as the highest range of velocities in this Nyquist limit. So we see this red building up to yellow, and then all of a sudden we see a blue color of showing the same magnitude, but now showing of a different direction of flow. Do we think actually that the flow pattern changed there? No, in fact, actually what happened is that we met the upper limit of our Nyquist limit when it comes to this assessment of direction of flow. And since we met that limit, the machine then just simply reversed that flow pattern because it was not able to sample it correctly or get the direction correctly. And so therefore it comes off as a blue jet, or sort of showing a false reversal of flow pattern. Again, this point right here showing where we met our Nyquist limit, or the top part of the range of velocities that we could assess. Very important concept, because the Nyquist limit is how we identify appropriate ranges and how we quantify flow patterns. So in other words, there's a certain Nyquist limit when it comes to cardiac exams for cardiac valves, for example. There's a certain Nyquist limit range that we look at for venous structures, and that scale, again, which is the Nyquist limit, has set parameters that we want to make sure are there when we're doing those particular examinations. And we'll talk about that in further detail when we go to those specific modalities. Very important to realize, we'll try to finish on some very big points. When it comes to a 2D picture, you want to be perpendicular to the ultrasound plane. The more perpendicular you are to that plane, the more ultrasound reflection you'll have, so the better the picture quality will be. The opposite is true when it comes to assessment of flow. For assessment of flow, you want to be as parallel to that flow as possible. So for a good 2D picture, you want to be as perpendicular to the structure as possible, and for a good flow pattern assessment, you want to be as parallel to flow as possible. The final mode, M mode, stands for motion mode, which is essentially just a 2D or B mode pattern over a single location of ultrasound, or a single ultrasound plane over time. Very high frequency or frame rate allows you to trace motion of different structures of interest. For example, we commonly use it to evaluate valves and heart wall motion, maybe vessel motion as well. So let's try to show you a picture. Essentially, what an M mode does is a dagger of ultrasound over a length of time. So let's just try to show a picture here. So here we identify these different potential M mode locations. This one, B, is what we show here in this picture. So B has an M mode going across. This is the mitral valve here. And what M mode allows you to do is see that motion of the mitral valve in a still picture. So again, M mode standing for motion mode. Essentially, it's a dagger of ultrasound displayed in a 2D picture over time. Okay, so now hopefully we've had a quick orientation into the concept of point-of-care ultrasound. We've also had a quick discussion into the physics of ultrasound, and now I hope for you to look at the other modules to really gain some hands-on experience on basic modalities that perioperative point-of-care ultrasound could be useful.